This presentation is entitled Cast Wedging and the Treatment of Angulated Long Bone Fractures in Children. It's presented by the Division of Pediatric Orthopedic Surgery at NYU Langone Medical Center in New York City. The authors have nothing to disclose. This video provides an introduction to the use of cast wedging in the treatment of angulated long bone fractures in children. This includes demonstration of long arm casting of a metaphyseal distal radius fracture in a pediatric patient, and estimation of the wedge's orientation and size based on the amount of correction desired for the fracture. A radiographic correlation is provided. Cast wedging was first described in 1936 by Kramer and Hurich. It's most commonly used in midshaft and distal fractures of the radius and of the tibia. The probability of loss of reduction in a fracture is proportional to the alignment deficit after closed reduction, and occasionally residual angulation can exceed the remodeling potential of a fracture. It is an alternative to repeat manipulation and reduction without the need to remove the cast. There is a success rate of higher than 90% reported by most authors for this procedure. Correction of 3 to 8 degrees in the coronal plane and of 6 to 16 degrees in the sagittal plane can be expected for most patients. Younger patients tend to achieve better corrections. Depending on where the wedge is placed in relation to the fracture, wedges are classified as direct, proximal, which have an increased lever for fracture reduction, and at the intersection, fracture fragments. Sizes are available between 10 and 30 millimeters. For distal radius fractures, 20 to 25 millimeter wedges are the ones most commonly used. Based on the shape and configuration, there are opening wedges, which cause tension on the concave side of the bone, and closing wedges, which compress the convex side, or a combination of both. The objective of this presentation is to outline the technique for cast wedging while providing an illustrative case. The main indication for the use of cast wedging is fracture redisplacement after closed reduction has already been performed. Fractures with increasing angulation parameters on radiographs in 2 or more subsequent visits should raise the suspicion for loss of reduction. Ultimately, the objective is to improve the alignment up to a point where remodeling can compensate for the remaining angular deficits. The angulation cutoff after which redisplacement is diagnosed vary considerably by fracture location and patient age. Fractures occurring in young children and the fractures that occur close to the physeal plate have the greatest potential to fully remodel. Therefore, the maximum angulation that can be tolerated varies between the patient's age, gender, fractured bone, location of the fracture in the coronal plane, and is disputed amongst authors. Cast wedging is best used in the first 3 weeks after a fracture. Contraindications to cast wedging include fractures that occur as a result of underlying pathology of the bone, in fracture dislocations, open fractures, and wedging for tibia fractures with a posterior vertex. Adverse effects of cast wedging may include pain, thermal injuries, muscle spasm, paresthesias, delayed capillary refill, skin breakdown, shortening of the fracture, and this tends to occur more commonly with closing wedges. In terms of pearls, when you're doing your cast wedge, you always want to be sure to apply sufficient padding to the original application of the cast. Ideally, synthetic material is preferred because this has a faster drying time. You want a mark that is to be anticipated over the cast using some sort of radio-opaque object. Commonly, a paper clip or a coin can be used. Then a permanent marker may be used to draw the affected bones over the cast. And you want to be thinking about the problem of fracture redisplacement as one of a tridimensional deformity. Possible pitfalls that may be encountered when performing a cast wedge include inaccurate placement, insufficient padding, under or oversized wedges used, inserting the wedge before the cast is completely dry, and variation in radiographic technique that makes interpretation of X-rays difficult. Prior to performing cast wedging, you want to have a checklist that should include a cast that is completely hardened and sufficiently padded. You want to be sure that the patient and the patient's family understand the expected amount of correction and possible complications that might occur. Material needed includes casting tape, stockinette, cast padding, adhesive tape, bandage scissors, water at room temperature, gloves, a sheet or underpad to protect the patient's clothing, wedge spacers of varying sizes, a permanent marker, a ruler, a cast saw with a vacuum, and a cast spreader. Step 1, you want to draw longitudinal lines to reach the fracture fragments and estimate the angulation of the fracture on the radiograph. We suggest using a paper clip to help locate the fracture. Step 2, you want to locate the center of rotational alignment at the intersection of the two lines drawn. Step 3, draw a line perpendicular to the bone axis through the chora. Draw a line using the fracture angle and the perpendicular line to it. Estimate the distance from point A to point B, and this is the size of the wedge needed. Next, cut the cast nearly circumferentially, being sure to leave a convex side intact to act as a hinge. Commonly, 270-degree cut is used. Next, insert, secure, and overwrap with casting tape the appropriate sized wedge that has been pre-selected. Wedging kits with multiple sizes are commercially available. To illustrate this technique, we've chosen a patient who is a 6-year-old female who fell directly on her right upper extremity. She was brought to the emergency room for immediate pain and deformity. The wrist was swollen and tender to palpation, the skin was closed, and her neurovascular findings were normal. Initial radiographs in the emergency room demonstrated significantly displaced both bone forearm fracture through the distal metaphyses. Initially underwent closed reduction and long arm cast application in the emergency room. Ultimately, the initial improvement was excellent, with only a residual angulation of 8.6 degrees in the coronal plane and 13.5 degrees in the sagittal plane. The patient was discharged from the emergency room and given instructions on cast care and on scheduling a follow-up visit within the week. At the week 1 visit, radiographs showed slightly increased displacement of the fractures in both coronal and sagittal planes. A radio-opaque object was placed on the dorsal aspect of the wrist prior to obtaining x-rays, so that if a wedge needed to occur at this visit, no additional x-rays would be required. Ultimately, the initial mild displacement at week 1 was accepted. However, at the week 2 follow-up visit, the fracture's angulation had again worsened, and now the fracture was considered to truly be redisplaced. At this visit, sagittal angulation had increased from 16.2 to 22.2 degrees, and the decision was made in consultation with the patient and her family to wedge the cast to improve its alignment. In this case, the fracture had a volar apex, and there was minimal rotational deformity or translation. Therefore, a wedge was cut on the dorsal aspect of the arm. By placing the wedge opposite to the apex of the fracture, an opening wedge acts as a fulcrum. By exerting a tensional force on the concave side of the forearm, the deforming forces of the fracture are countered, and the concavity is progressively straightened, causing the fracture to align as well. After wedging the cast, radiographic controls showed significant improvement in coronal and sagittal angulation for both fractures. At the 3rd week following injury, it was noted with repeat radiographs that following cast wedging, no additional displacement had occurred and the fracture was now stable. By the next visit, both fractures had grown callous and the cast was removed. Additional remodeling had occurred as well. At the final visit, the angulation of the radius had improved to 3.6 degrees in the coronal plane and 6.4 degrees in the sagittal plane. The ulna had also remodeled appropriately. In sum, this video has demonstrated the appropriate use and appropriate technique for performing cast wedges for treatment of the pediatric population when initial and follow-up radiographs for fractures of the radius and also of the tibia demonstrate increasing angulation. Thank you.